Good morning, sir. So, do we start?
If Dr. Dhyani has joined, I think we can start. Dr. Dhyani, sir, when he'll join, we can start.
Yes, sir. Good morning, sir. So now we'll be starting the presentation. Dr. Mohammed will be presenting gender dysphoria.
Hi, my name is Dr. Mohammed Khan. I am present gender dysphoria. First start about definition. Gender dysphoria is marked and persistent incongruence between an individual experience or expressed gender of assigned sex. Incongruence is unhappy about anatomical sex. First time in DSM-5, in previous DSM was called this gender identity disorder. In DSM-5, it's called gender dysphoria. In ICD-10, under disorder of adult behavior and personality in gender identity disorder. In ICD-11, gender incongruence under a new chapter for sexual health and sexual disorder. Types of in gender dysphoria. First of transgender who identifies themselves differently from the gender they are born with. Second is transsexual who want to have body of another sex. Third is gender queer, those who feel they are between genders or both genders. These are the types. Diagnosis and clinical features. In children, incongruence between expressed and assigned gender with the more desire to be another gender or insistence that one is another gender. Prefer clothing, toys, playmates of another gender. And third is dislike one's sexual anatomy and desire to change sexual anatomy. This is the gender dysphoria potential cause and contributing factors. Many causes: borderline personality disorder, sexual trauma, post-traumatic stress disorder, social contagion, autism spectrum disorder. And in clinical feature in adolescents and adult, incongruence between expressed and assigned gender, desire sexual characteristics to be treated as another gender, believes that has typical feelings and reactions of another gender. Gender dysphoria in DSM-5 called gender dysphoria, in ICD-10 called as gender identity disorder. Several disorder absent in ICD-10. In gender dysphoria duration more than 6 months. In children, at least minimum 6 symptoms, more than or equal 6 symptoms present in these symptoms. First symptom is desire to be of another gender, dressing like other gender, preference for other gender roles in play, rejection of same gender toys, preference of other gender playmates, dislike one's anatomy, and desire for physical characteristic of other gender. This is the children, and in adult, more than 2 symptoms present in these 5 symptoms. First is conflict between experience, gender, and sexual characteristics. Second, desire to remove one's primary or secondary sexual characteristics. Desire for other gender primary, secondary sexual characteristics. And fourth is desire for another gender. Fifth is feeling one has psychological characteristics for another gender. And next is distress or functional impairment, disorder of sexual development. And these are the differential diagnosis. The first is schizophrenia, body dysmorphic disorder, and transvestic disorder. Etiology of gender dysphoria. First is biological factor. Male only developed by Y chromosome. If no Y chromosome, then fetus has property for female sex. The second, brain organization theory refers to muscularization and feminization of brain in vitro. Testosterone affect brain neurons, contribute to muscularization of brain areas such as hypothalamus. Second is psychosocial factor. In this, segment fraud result from conflicts experienced by children with cerebral triangle. Real family events and fantasies are involved. Mother and child relationship is paramount, establishing gender identity. This is the type of dysphoria. Depend on social, body, and mind. This is course and prognosis. Begins around 3 years of age. At puberty, increased anxiety related to anticipated changes their body. Comorbidities. In children, depressive disorder, anxiety disorder, impulse control. Some fall on autism spectrum disorder related to intrauterine hormone exposure. In adult, depressive disorder, anxiety disorder, suicidality, self-harming behavior, and substance abuse. Late onset gender dysphoria have more significant fluctuation in the extent of their distress and more ambivalence about and less satisfaction after sex reassignment surgery. Epidemiology, gender dysphoria, male and female ratio 4.5 is to 1 in children. This is the graph for 80% of trans students feel unsafe at school because of their gender expression. Next is treatment. Treatment in children, individual, family, and group therapy. In adolescent, as gender non-conforming children approach puberty, somehow intense fear and preoccupation related to the physical changes. Puberty blocking gonadotropin releasing hormone agonist that can temporarily block the release of hormone that leads to secondary sexual characteristics, giving adolescents and their families time to reflect on the best option moving forward. Second is hormone therapy. Hormone therapy, transgender men, testosterone every week, giving testosterone in every week. That's lead to changes, increase acne, muscle mass, initially libido, cessation of menses, later deepening of voice, increased body hair growth, enlargement of clitoris. In this, we monitor HB, increase RBC, and check LFTs, cholesterol, and diabetes level. Transgender women take estrogen, testosterone blocker, and progesterone in combination that leads to softening of the skin and redistribution of fat that leads to breast growth. In transgender women, take for treatment, take estrogen, testosterone blocker, and progesterone in combination that leads to softening of the skin and redistribution of fat that leads to breast growth. No changes in voice in this. Avoid cigarette smoking or prolactin level test. Third is surgery. First is top surgery or chest surgery. Transgender men may have surgery to construct a male counter chest. Trans women may have breast augmentation. Second is bottom surgery is less common. Transgender men may have a metoidioplasty in which the surgeon frees the clitoris from the ligament and attaching it to the body and adds tissue, increasing its length and girth. Second is scrotoplasty, the placement of testicular implants in another way to create male-appearing genitalia. Third is phalloplasty, the creation of a penis is less commonly performed because it is expensive, involve multiple procedures. In transgender women, treatment is vaginoplasty. This is the whole overview of gender dysphoria. First patient with gender dysphoria go to the any specialties, urology, surgery, endocrine, and others. Then they refer to mental health professional for into psychiatry evaluation. In this way, symptoms and comorbidities, intellectual capacity, then treatment and tripartite therapy, psychotherapy, hormone therapy, and surgery. Thank you.
Thank you, Dr. Mohammed. Now, Dr. Gulmer will be presenting on gender dysphoria. On default movement.
Good morning, everyone. My topic is default mode network. So the definition is the default mode network is a network of interacting brain regions that is active when a person is not focused on the outside world. And we can measure it with the fMRI technique. Areas of the brain that form a network and are active when we are not task focused. So this is also referred to as the task negative network. During task positive activity, the DMN is less active. Every person has one of these networks. This may play a specific role in illnesses such as depression, autism, and schizophrenia. Anatomically, it is a large-scale brain network primarily composed of the medial prefrontal cortex, posterior cingulate cortex, and angular gyrus. It is best known for being active when a person is not focused on the outside world and the brain is at wakeful rest, such as during daydreaming and mind wandering. It can also be active during detailed thoughts related to external task performance. Other times that the DMN is active include when the individual is thinking about others, thinking about themselves, remembering the past, and planning for the future. The DMN has been shown to be negatively correlated with other networks in the brain, such as attention networks. Evidence has also pointed to disruptions in the DMN of people with Alzheimer's and autism spectrum disorder. So for the anatomy, the functional hubs are information regarding the self. So the first one is posterior cingulate cortex and precuneus, combines bottom up, which is not controlled, attention with information from memory and perception. The ventral, which is the lower part of PCC, activates in all tasks which involve the DMN, including those related to the self, related to others, remembering the past, thinking about the future, and processing concepts plus spatial navigation. The dorsal part of PCC involves involuntary awareness and arousal. The precuneus is involved in visual, sensory, motor, and attentional information. Medial prefrontal cortex, decisions about self-processing such as personal information, autobiographical memories, future goals and events, and decision-making regarding those personally very close such as family. The ventral part is involved in positive emotional information and internally valued reward. Angular gyrus, this is involved in connects perception, attention, spatial cognition and action, and helps with parts of recall of episodic memories. Dorsal medial subsystem, this is the system which makes us think about others. So the functional hubs are PCC, MPFC, and angular gyrus. Dorsal medial prefrontal cortex involved in social directed thoughts such as determining or inferring the purpose of others' actions. Temporoparietal junction reflects on beliefs about others, also known as theory of mind. Lateral temporal cortex, retrieval of social, semantic, and conceptual knowledge. Anterior temporal pole, abstract conceptual information, particularly social in nature. Next is the medial temporal subsystem. The functional hubs are PCC, MPFC, and angular gyrus. Hippocampus, formation of new memories as well as remembering the past and imagining the future. Parahippocampus, spatial and scene recognition and simulation. Retrosplenial cortex, spatial navigation. Posterior inferior parietal lobe, junction of auditory, visual, and somatosensory information and attention. This is the fMRI of the brain during the default mode network. The functions of the default mode network are autobiographical information, memories of collection of events and facts about oneself, self-reference, referring to traits and descriptions of oneself, emotions of one's self, reflecting about one's emotional state, thinking about others, theory of mind, thinking about the thoughts of others and what they might or might not know, emotions of others, understanding the emotions of other people and empathizing with their feelings, moral reasoning, determining a just and unjust result of an action, social evaluations, good, bad attitude judgments about social concepts, social categories reflecting on important social characteristics and status of a group, social isolation, a perceived lack of social interaction, remembering the past and thinking about the future, recalling events that happened in the past, envisioning events that might happen in the future, detailed memory related to specific events in time, understanding and remembering a narrative. Clinical significance, the default mode network has been hypothesized to be relevant to disorders including Alzheimer's, autism, schizophrenia, depressive disorder, chronic pain, post-traumatic stress disorder, and others. So for Alzheimer's disease, people with Alzheimer's disease show a reduction in glucose, which is energy used within the areas of the default mode network. These reductions start off as slight decreases in patients with mild symptoms and continue to large reductions in those with severe symptoms. Surprisingly, disruptions in the DMN begin even before the individuals show signs of Alzheimer's disease. Plots of the peptide amyloid beta, which is thought to cause Alzheimer's disease, show the buildup of the peptide is within the DMN. This prompted Randy Buckner and colleagues to propose the high metabolic rate from the continuous activation of DMN causes more amyloid beta peptide to accumulate in these DMN areas. These amyloid beta peptides disrupt the DMN, and because the DMN is heavily involved in memory formation and retrieval, this disruption leads to the symptoms of Alzheimer's disease. Next is autism. DMN is thought to be disrupted in individuals with autism spectrum disorder. These individuals are impaired in social interaction and communication, which are tasks central to this network. Studies have shown worse connections between areas of the DMN in individuals with autism, especially with the MPFC, which is involved in thinking about the self and others, and the PCC. The more severe the autism, the less connected these areas are to each other. It is not clear if this is a cause or a result of autism, or if a third factor is causing both. For depression, rumination, one of the main symptoms of major depressive disorder, is associated with increased DMN connectivity and dominance over other networks during rest. Such DMN hyperconnectivity has been observed in first episode depression and chronic pain. Altered DMN connectivity may change the way a person perceives events and their social and moral reasoning, thus increasing their susceptibility to depressive symptoms. So this is the depressed brain. There is increased and dysregulated DMN activity, and the core symptoms hence increase, which are guilt, hopelessness, ruminations, and negative thoughts. For PTSD, lower connectivity between brain regions was found across the default network in people who have experienced long-term trauma, such as childhood abuse or neglect, and is associated with dysfunctional attachment patterns. Among people experiencing PTSD, lower activation was found in the posterior cingulate gyrus compared to controls, and severe PTSD was characterized by lower connectivity within the DMN. ADHD, adults and children with ADHD show reduced anti-correlation between the DMN and other brain networks. The cause may be a lag in brain maturation. More generally, competing activation between the DMN and other networks during memory encoding may result in poor long-term memory consolidation, which is a symptom of not only ADHD, but also depression, anxiety, autism, and schizophrenia. The DMN may be modulated by the following interventions and processes. First is acupuncture, deactivation of the limbic brain areas and the DMN. It has been suggested that this is due to the pain response. Antidepressants, abnormalities in DMN connectivity are reduced following treatment with antidepressant medications in PTSD. Attention training technique. Research show that even a single session of attention training technique changes functional connectivity of the DMN. Then deep brain stimulations, alterations in brain activity with deep brain stimulation may be used to balance resting state networks, meditation, and physical activity and exercise. Psychedelic drugs, reduced blood flow to the PCC and MPFC was observed under the administration of psilocybin. These two areas are considered to be the main nodes of DMN. One study on the effects of LSD demonstrated that the drug desynchronizes brain activity within the DMN. The activity of the brain regions that constitute the DMN becomes less correlated. Psychotherapy. In PTSD, the abnormalities in the default mode network normalize in individuals who respond to psychotherapy interventions. Last is sleep deprivation. Functional connectivity between nodes of the DMN is the resting state is usually strong, but sleep deprivation results in a decrease in connectivity within the DMN. Recent studies suggest a decrease in connectivity between the DMN and the task-positive network as a result of sleep loss. That's it. Thank you.
Thank you. I would like to open the floor for any questions or any comments.
Are there any queries from anyone? Okay, I would like to commend both the speakers for presenting this. I think, but we could have guided rather than presenting a PPT in format, we can present in in a PDF, maybe in a PPT format, and also make it less technical so that people can understand. That's only my feedback. And anyway, it was a good effort from both the speakers to present. The topic was a little difficult, but still they presented it well. I'll hand it over to the moderators to conclude the session.
Thank you, sir. Both the presentations were really nice. And I would want to say that Dr. Mohammed did a really good effort, because this was after 8 years that he did something academically. So this was a really good effort. Thank you. So I'll end the meeting.
Yes, yes. Thank you.
Thank you, sir.